Good morning, everyone. So I would like to pay attention for some missing parts connected with the last credit. So if you prepare for the credit, please pay attention for the lecture 2. During the previous lecture, it was presented two pictures in 3D with the phantogram and two-dimensional part, and you missed this part. It was presented. So 10% of your practical parts were missing because you omit the lecture. You are not prepared properly for the practical part. I will pay attention on the page on the Anatomy 3A, on the Anatomy 3A website. Most of you didn't log in, but it's a big support of your work. So, for example, I describe to you that you can use the three-dimensional phantographic red cyan glasses to see the space, to see the height, breadth, and the depth. And please pay attention. I ask you, pay attention. Where is the ventral or the dorsal side? So you recognize on this picture mammillary bodies and the oculomotor nerve. So it's the ventral side, and the left and the right side. So if you pay attention, the right side is dissected, the right side is not dissected, the left side is dissected. This is the level of the mesencephalon. When you cut the mesencephalon, you have always presentation on the transverse section. On the practical, it was the vertical presentation. But you have to recognize not only the upper and the lower side, the olive, lower part, mammillary bodies, upper part. So you pay attention that at the level of the brainstem, the dark side, black color, it will be only substantia nigra. So it was easy, but not given in the all atlases. But you have to recognize this is the analyzing of your state of the knowledge in the three-dimensional and two-dimensional picture. And let's follow your previous credit. So just below, if you look down, so you will recognize given on the lecture two answers. Please pay attention. This was presented, and this one was presented. So I will repeat this part, especially to pay attention for the two missing pictures. Two missing pictures, it means 10% of your answers. So let's go to see the missing parts of the previous lecture, because we will continue this lecture with Dr. Morton, because this part connected with the upper and the lower motor neurons of the facial nerve will be connected with the palsy of the upper and the motor neuron. So, and the next, today we will continue peripheral part, especially the part connected with the two amazing parts of the facial nerve, because the facial nerve is the motor nerve, and the accessory part, 7A, is called the intermediate nerve, and the intermediate nerve will be connected with the parasympathetic fibers and the sensation fibers connected with the taste. So this additional part, 7A of the facial nerve, will be analyzed today, and the fate of the branches connected with the greater petrosal nerve and the chorda tympani. Just now, a few minutes of the missing picture given during the last retake of the central nervous system. We have to repeat because it will be connected with the next presentation, connected with the description of the facial nerve palsy. Facial colliculus on the dissected part, it's visible the nucleus. Is the nucleus of the facial colliculus, but this is not nucleus of the facial nerve. So the nucleus which is visible here is the nucleus of the abducent nerve. At the floor of the fourth ventricle, at the place of the facial colliculus, is located the abducent nucleus and abducent nerve partly. Look here, this is the abducent nerve connected with the facial, connected with the abducent nucleus located at the facial colliculus. So the nucleus of the facial nerve is located completely laterally, completely not at the place which is called the facial colliculus. The facial motor nucleus is located just here on the lateral side, and the fibers are going to the below the nucleus of abducent nerve. Let's go to see the nucleus, facial nucleus. Fibers are rising up, omits the abducent nucleus, and they are rising, are going peripherally to supply the muscle of the facial expression. So this part, this turn along the abducent nucleus is called the internal genu of the facial nerve. This is called the internal genu. The fibers are going around the abducent nucleus, and the point of the facial colliculus not indicate the position of the facial nucleus. This is tricky part. And let's go to see what is going closely to the facial colliculus. So it means abducent nerve and the fibers of the internal genu. So along vertically from the lower to upper part is going some of the fibers which are very important. Just here is the medial longitudinal fasciculus. The medial longitudinal fasciculus is a center of connection for the oculomotor nerve, trochlear nerve, and abducent nerve. The medial longitudinal fasciculus carries information about direction that eyes should move. It connects the cranial nerve, third, fourth, and sixth, and integrates movement by the gaze center, frontal eye field, and the information about the movement of the vestibulocochlear nerve, its integral component of the saccadic eye movement, as well vestibulo-ocular and the optokinetic reflexes. lesion of the medial longitudinal fasciculus produces slowed or absent adduction of the ipsilateral eye, associated with the involuntary jerky eye movements, nystagmus. And now I would like to pay attention for another common mistakes. So just now, if you pay attention for this venogram, so it was given the letter description R for the picture, but the structure which was visible just here, superior sagittal sinus, is unpaired. Don't write without the thinking, without the analyzing, the right superior sagittal sinus, because it is not true. We have in the left. This is unpaired structure, so it's mistake. So please pay attention. Only pair structure, even on the picture, is indicated the left and the right side of the structure. Be careful, because it's quite important to think during the credit, not only to memorize. Just now, I would like to continue our analyzing of the facial nerve, especially the neurons of the facial nerve, presented in the nutshell analysis of the Dr. Morton. Dr. Morton, welcome.
Okay, let's talk about facial palsy and stroke and answer the what questions. What role does the facial nerve play in facial expression? And what is facial palsy and how does it happen? And what effect does a stroke have on facial expression? Okay, so lower motor neurons of the facial nerve innervate ipsilateral facial muscles. Now, what does that mean? Well, here's the lateral picture of the head, and there's the pons, which gives rise to the facial nerve, which traverses the internal acoustic meatus and then gives rise to a branch called the facial nerve proper, which descends in the facial canal of the temporal bone. And so the course into the axon exits the stylomastoid foramen, which is not shown in this picture, and that facial nerve proper continues through the parotid gland and then gives rise to 5 branches that innervate muscles of facial expression. And those muscles include the frontalis muscle that wrinkles your forehead, and orbicularis oculi that closes your eye, and nasalis muscle that flares your nostrils, and zygomaticus muscles which make you smile, and orbicularis oris muscles that help you close your mouth and pucker your lips. The facial nerve does not innervate the temporalis or masseter muscles, which are muscles of mastication, and they are not innervated by facial nerve, but they are innervated by the mandibular branch of the trigeminal nerve. So let's do this again in this picture. We're in this coronal section up top. We can see the pons, and the pons contains the facial nucleus. And the facial nucleus, as all nuclei, are a collection of cell bodies. Some of those cell bodies give rise to lower motor neurons that innervate the forehead muscles, and some lower motor neurons give rise to axons that innervate muscles of the lower face, like this. And this occurs bilaterally. In other words, lower motor neurons of the facial nerve innervate ipsilateral facial muscles. Now, facial palsy, known as Bell's palsy, is injury of the facial nerve after it exits the pons, and it creates a palsy or paralysis of ipsilateral facial muscles. What does this mean? Well, this can occur right basically at the facial motor nucleus, but it could occur right as the facial nerve exits the pons and goes into the internal acoustic meatus. That may occur like an acoustic neuroma, or like as the facial nerve proper descends through the facial canal, which would be something like inflammation in there. It could also include where mumps or a tumor in the parotid gland would compress the facial nerve, or just branches of the facial nerve going into the face, like what happened with Sylvester Stallone with forceps during his delivery when he was a wee baby, that gives him that characteristic smile. All right, so let's do it again, except with this picture. So in this picture, that is showing the facial nerve, or those axons are all part of the facial nerve, which if we then injure, you denervate both axons going to muscles of the forehead and the lower face, and that results in shing, complete paralysis of that side, complete paralysis of the facial muscles on that side of the lesion. So, paralysis of facial muscles, half of the face is paralyzed on the side of the injury or weakness, and that results in a smooth forehead, inability to close eyes tight or to blink, a droopy nose, corner of the mouth drops, and there's a smooth face. So here's a picture of a patient, and let's do the same thing. Notice on the side of the facial palsy, a smooth forehead compared to the other side. Smooth ring around the eyes compared to the other eye, and they can't close it or difficulty closing it. Notice that this corner of the nose droops when compared to the other. And this, if you were to say, hey, show me your teeth to a patient, on the right normal side, you can see the smile and teeth, but on the palsy side, it gives this crooked smile. And then you'll notice that the faces seem smoother because the muscles are not contracting. So in facial palsy, both upper and lower face are paralyzed. Now, but facial palsy is called Bell's palsy after the anatomist Sir Charles Bell, who wrote in some pamphlets and then journal articles about what he observed in this facial paralysis. He also identified this nerve called the long thoracic nerve that innervates the serratus anterior muscle. So long thoracic nerve is also called Bell's nerve. I don't know why it didn't stick. Okay, so some orientation and some pictures. There's a lateral view of the brain on the right side, and there is the precentral gyrus, also known as the primary motor cortex, and there is the pons. And we're going to do a very creative coronal cut like that, and gives us a picture like this. When there is our coronal section through the brain on the right side, there's the precentral gyrus, and there is the pons. So now if we take a look at some other landmarks, so there's the lateral ventricle and thalamus, and then there's the globus pallidus and the putamen, which are part of the basal ganglia, and between those structures is the internal capsule where the axons of upper motor neurons are going to course. And then there's our midbrain of the brainstem, and then there's the pons, which is going to house our facial motor nucleus. So let's take a cross section, and there is the facial nucleus in a cross section of the pons, and this is what it's going to look like in our little schematic. Okay, now also we see this structure called the motor homunculus, and the motor homunculus is a somatotopic organization of the primary motor cortex. What does that mean? Well, muscles that are densely innervated, think face, are supplied by lots of neurons and therefore require more space in the cerebral cortex. In contrast, muscles that are less innervated, like the trunk, so are supplied by fewer of neurons, and therefore they require less space in the cerebral cortex. So let's now talk about upper motor neurons. So upper motor neurons of the facial nerve arise from the contralateral cerebral cortex. And there's an exception with the forehead, so hold that thought. So here in this section, we see the facial nucleus. And there in the upper right cerebral cortex, by the forehead part of the homunculus, an upper motor neuron descends through the internal capsule, synapses with a lower motor neuron that goes specifically to the forehead. And then back up into the motor homunculus, you see now upper motor neuron that comes from the lower part of the face, descends and synapses with lower motor neurons that then innervate muscles of the lower face. So upper motor neurons of the facial nerve arise from the contralateral cerebral cortex. Bonk, bonk. But there's a forehead exception. So what is this exception of the forehead? Well, facial motor nucleus to the forehead is stimulated by upper motor neurons from the contralateral cerebral cortex, shing, but as well as the ipsilateral cerebral cortex as well, shing. That is pretty cool. That's going to be very important in a few minutes. Now, if we now take a look at the lower face, lower motor neurons that innervate muscles of the lower face only receive upper motor neurons from the contralateral cerebral cortex like that. So let's do a little nutshell moment here, okay? So lower motor neurons that innervate muscles of the upper face, okay, receive both crossed and uncrossed upper motor neurons. Whereas lower motor neurons that innervate muscles of the lower face receive only crossed upper motor neurons. All right. So now what happens in a stroke is that a stroke occurs when there is an injury to a supranuclear lesion by supranuclear meaning the facial motor nucleus, where the upper motor neuron is injured. This results in palsy of the contralateral facial muscles with sparing of the forehead. What does that look like? Well, here we have a picture, and there's the facial nucleus, and so supranuclear lesion is anywhere in that area. Injury of the brain tissue that would injure those upper motor neurons is going to result in paralysis of the contralateral facial muscles with sparing of the forehead. So there is a lesion. There's a lesion of upper motor neurons on the right side. And as a result, the lower motor neurons of the facial nerve on the left side do not receive innervation, which results in contralateral facial muscle paralysis like this. But wait a Star Trek second here. You talked about that there's something funky about the forehead nucleus. So we can't forget that upper motor neurons from the ipsilateral side also can stimulate the lower motor neurons that go to that forehead. And as a result, that is what a stroke looks like. Sparing of the forehead and paralysis of contralateral lower face. So let's do that again. That was kind of fun. So if we lesion the upper motor neurons on the right side, there is no contralateral upper motor neuron stimulation of the facial motor nucleus on the left side, but we have ipsilateral upper motor neuron innervation to the forehead like this, which then allows the forehead on the left-hand side to be stimulated. So sparing of the forehead on the left, paralysis of the contralateral lower face, by contralateral meaning opposite side of the lesion. All right. Now, there's an acronym, FAST, F-A-S-T. FAST is an acronym to help detect and then improve responsiveness to the needs of someone who's having a stroke. So in this acronym, F stands for facial drooping of the face. And it's a section of the face, it's usually on one side, that's drooping and hard to move, and they have this crooked smile. And then an arm, it's arm weakness, like the person who may be having a stroke is unable to raise their arm fully, or they just can't even move it. Speech, where the patient may not be either slurring their speech or not able to speak at all or understand. And then timing, if any of the symptoms above are shown, facial paralysis, can't move the arm, speech problems, time is of the essence. Call emergency services, call 911, and or take them immediately to the hospital. To be able to get treatment. The faster the treatment, the better chance they have of being able to have regaining facial movement in arm and so forth. So here we see a patient before a stroke. Notice that the upper forehead is wrinkling in the smile in a very beautiful symmetrical smile. Now after stroke, notice that there's sparing of the forehead on the left, but that on the left there's paralysis of that lower face, crooked smile, which means that the stroke happened on the right side. So let's do a couple of practice things, shall we? This patient's asked to smile. Identify the most likely location of the nerve injury. There is the choices. So pause if you want here. Now I'm going to go through and answer this question, but pause if you want to think through this on your own. So when I look at this, and they're like the patient smile, I can see on the left they're smiling, but that on the right, there's no wrinkling of the forehead, the right nose is drooping, and the right corner of the mouth is down, which means it's all on the same side. So I'm thinking lower motor neuron lesion, and if it's on the right, that means it's a right-sided one. And the facial canal is a coursing of the lower motor neurons, so I think it's a right facial canal problem resulting in right facial Bell's palsy. That was fun. Let's do another one. So this patient's asked to smile. Identify the most likely location of her nerve injury. Pause if you want to think through this, but I'm going to go through and describe the answer now. So when I look at this, I'm like, all right, I can see that that corner of the right side of the mouth is drooping, as is the nose. But look, her forehead is wrinkled. So I'm thinking now upper motor neuron problem, and it's going to be of the facial paralysis, the contralateral side. So it's a primary motor cortex in my choices. So I'm going to go with a left primary motor cortex stroke. Okay, let's have an in a nutshell moment now. Facial or Bell's palsy is a lower motor neuron injury in the same side as the palsy and complete paralysis on that side of the face. In contrast, a stroke is an upper motor neuron injury, which is the opposite side of the palsy, with lower face paralysis and sparing of the forehead. And that, my friends, is facial palsy and stroke in a nutshell.
And now, quite complicated presentation of Peter Abrahams. Taste and the parasympathetic components, which are described as a 7A additional part of the facial nerve, intermediate nerve. Just now, Peter, please.
We're going to look at the greater petrosal nerve and the role it plays in the secretomotor supply of the nasal and palatine glands. It's worth remembering that it is not only a secretomotor nerve, but it is also transmitting taste back to the brain from the posterior aspects of the palate. So once again, we're going to look at the pure anatomical pathway initially. We see that the nucleus for the secretomotor fibers is the superior salivary nucleus. This nucleus is associated with the seventh cranial nerve. But just to remind ourselves that the taste fibers are going to enter the tractus solitarius. We see that these fibers travel out and in the case of taste, in the nervus intermedius, which we described in more detail in the audio-visual demonstration of the chorda tympani. These fibers join the seventh cranial nerve as it passes into the internal auditory meatus, together with the seventh and eighth nerve. We see that it joins the seventh nerve just before the geniculate ganglion. The geniculate ganglion itself is going to be the site for the cell bodies for taste. Now, the parasympathetic fibers for the greater petrosal nerve leave the geniculate ganglion and head superiorly as the greater petrosal nerve. This greater petrosal nerve passes through the roof of the petrous temporal bone into the middle cranial fossa between the layers of the dura. It actually passes under the trigeminal ganglion and it reaches the foramen lacerum. It passes just down into the foramen lacerum and then anteriorly into the pterygoid canal. It's joined by the deep petrosal nerve, which is a sympathetic nerve from the plexus on the internal carotid artery, and then it becomes known together, these two nerves, as the nerve of the pterygoid canal. The nerve of the pterygoid canal passes forwards into the pterygopalatine fossa, where it then enters the pterygopalatine ganglion. This is often known conveniently and sensibly as the hay fever ganglion. Within the ganglion, the parasympathetic fibers synapse, but the sympathetics from the deep petrosal nerve simply pass through and distribute to each of the nerves that leaves the pterygopalatine ganglion. These parasympathetic fibers are distributed to the nose, the sinuses, the palate, the nasopharynx, and eventually to the lacrimal gland. And then finally we see that taste is returning from the palate in the greater and lesser palatine nerves into the greater petrosal nerve and back with their cell bodies in the geniculate ganglion. So now we're going to look at a little more detail of these parasympathetic fibers to the nose, the sinuses, etc., and also to the lacrimal gland. Once again, you have the opportunity of seeing the questions first and answering them if you wish. So we see on this drawing here that the brainstem, where the nucleus is on the left-hand side, and the first question we must answer is which cranial nerve is associated with the parasympathetic fibers for these secretory functions. And the answer again is the facial nerve, with its nucleus in the brainstem. As with the chorda tympani, we ask what is the course and function of the facial nerve. And we can see that the facial nerve is entering the middle ear via the internal acoustic meatus or auditory meatus. It passes through the geniculate ganglion and the cavity of the middle ear in the facial canal before exiting the skull via the stylomastoid foramen. It's going to provide motor supply for the muscles of facial expression. Then we ask ourselves, what is the parasympathetic nucleus associated with 7? And this is the superior salivary nucleus, shown here in red. We can ask whether these preganglionic parasympathetic fibers travel in 7 or do they travel in another nerve with 7. and although we regard them as being in 7, they actually travel in a small nerve, the nervus intermedius, with both taste and some general sensation in 7. Next. So what happens to these preganglionic parasympathetic fibres when they reach the geniculate ganglion? Well, they leave the facial nerve at this point and exit the middle ear through its roof as the greater petrosal nerve. Note, of course, that they do not synapse in the geniculate ganglion. Then what happens to this greater petrosal nerve after it leaves through the top of the middle ear? Well, it actually enters the middle cranial fossa under the dura and heads for the top of the foramen lacerum. So which fossa is the greater petrosal nerve heading for, and how does it get there? Well, it's heading for the pterygopalatine fossa, and it passes across the top of the foramen lacerum and enters the pterygoid canal. Then we must ask, what is the name of the ganglion that lies in the pterygopalatine fossa? And this, of course, is the pterygopalatine ganglion. We'll see shortly that the sympathetic fibres also pass through the pterygopalatine ganglion exactly the same as they do through all of the parasympathetic ganglia in the head, but we must ask ourselves where they come from. And they come in the form of the deep petrosal nerve, which are sympathetics, and they arise as a plexus on the internal carotid artery in the cavernous sinus. The nerve of the pterygoid canal consists of both the parasympathetics and also the sympathetics that we've just mentioned. We can ask ourselves what happens to these preganglionic parasympathetic fibres when they reach the pterygopalatine ganglion. And the answer is that they synapse here and become postganglionic fibres. So actually, what are the branches of the postganglionic parasympathetic fibres that emerge from the pterygopalatine ganglion? Amongst others, there's the greater and lesser and nasopalatine, the pharyngeal and the lacrimal branches. There are other little branches to both the sinuses, the teeth and the orbit. And then we must ask, what fibres actually carry these postganglionic parasympathetic fibres from the ganglion to the end organ? And as always, it is a branch of the trigeminal nerve. In this case, it's going to be branches of the maxillary division. So here we can confirm what are the actual branches of 5 that carry the parasympathetics to their destinations. And in each case, it is one of the branches of the maxillary division. They accompany each of these parasympathetic fibres to their end organs. So then we must ask, what else passes through the pterygopalatine ganglion and is distributed to all its branches? And once again, it is sympathetics for vasoconstriction. Now, somewhat more complex is the fact that these postganglionic parasympathetic fibres must also reach the lacrimal gland if we're going to call the pterygopalatine ganglion the hay fever ganglion. So let's pose the question, how do these postganglionic parasympathetics reach the lacrimal gland? It is indeed a complex route. They join the zygomatico-temporal nerve, and then in the orbit they cross it and join the lacrimal branch of the ophthalmic division of 5A to be carried to the gland itself. We should remind ourselves that the lacrimal nerve is a pure sensory nerve that supplies the outer canthus of the eye. Then we have to ask ourselves what other sensory fibres are carried in some of the branches of the pterygopalatine ganglion. And there are, of course, taste fibres in both the greater and lesser palatine nerves. There is, of course, no taste in the nose or the nasopharynx. Here these fibres are shown in blue, travelling with the nerve to the pterygoid canal. So we can ask ourselves, how do these taste fibres travel centrally, and where are the cell bodies? Well, they're travelling back with the greater petrosal nerve, and their cell bodies are in the geniculate ganglion, just as they were for the chorda tympani. So here is the final situation in the pterygopalatine fossa. We've omitted taste for convenience, but we can see how each of the branches of the pterygopalatine ganglion each contain the parasympathetic secretomotor, the sensory, a branch of 5B on this case, and also the small sympathetic for vasoconstriction in each branch. we can see how the parasympathetic travel on the zygomaticotemporal and then cross the orbit to reach the lacrimal nerve, to reach the lacrimal gland. And finally, our last picture shows the final situation in completion. So that is a rather short summary of a rather complex pathway of the parasympathetic pathways to both the nose, the sinuses, and the lacrimal gland. The nerve called the chorda tympani. It's a little complicated, but at first it's worth saying that this is a dual-purpose nerve. It's going to carry parasympathetic fibres to the submandibular and sublingual glands, but it's also going to carry back taste from the anterior two-thirds of the tongue. First of all, we're going to look at its pathway purely from an anatomical point of view. When we look at the nuclei, we'll see that there are secretomotor fibres coming from the superior salivary nucleus. And then we'll see that the central connections for taste are transferred into the tractus solitarius. The secretomotor fibres pass into the nervus intermedius, and the taste fibres return via it. The nervus intermedius is simply part of the seventh cranial nerve, but it's a small separate piece that contains the fibres that we've mentioned together with a small sensory branch. It passes into the internal acoustic meatus together with 7 and 8. It then joins the seventh nerve just before it reaches the geniculate ganglion. We see that the geniculate ganglion is simply a mass of cell bodies for taste, and also the cell bodies of the small amount of sensory fibres that occur in 7. The parasympathetic fibres simply pass straight through the ganglion with, of course, no synapses. The chorda tympani leaves the facial nerve near the floor of the middle ear. It crosses back into the middle ear, crosses the tympanic membrane, and then exits from the middle ear via the anterior canaliculus and exits the skull through the petrotympanic fissure. Having left the skull, it then runs down to join the lingual nerve from behind. It actually grooves the spine of the sphenoid, lies deep to the lateral pterygoid, and then joins the lingual nerve about 2 centimetres below the skull. Travelling on the lingual nerve, it reaches the submandibular ganglion, where the parasympathetic all synapse. The sensory branch of the lingual nerve simply passes through the ganglion, travelling back towards the brain. At this point, also passing through the submandibular ganglion are some sympathetic fibres that have arisen from a plexus on the facial artery. These, as always, sympathetic fibres that simply pass through the ganglion and are for vasoconstriction only. The parasympathetic fibres, meanwhile, simply pass to the submandibular, sublingual and anterior lingual glands. And then finally we see that the taste from the anterior two-thirds of the tongue passes back in the chorda tympani, and we're going to see shortly that the cell bodies are in the geniculate ganglion in the middle ear. We're now going to look at slightly more detail the parasympathetic pathways to the submandibular and sublingual glands. Once again, this is in the format of questions so that you can answer if you wish before I give you the answer. So we see on the left side of the drawing there is the brainstem with the big black blob, and we're asked which cranial nerve is associated with the parasympathetic fibres for these secretory functions. And of course the answer is the facial nerve, cranial nerve number 7. What is the actual course and function of the facial nerve? And we'll see that the facial nerve enters the middle ear via the internal auditory meatus. It passes right through the geniculate ganglion and the cavity of the middle ear before exiting the skull via the stylomastoid foramen. It supplies the muscles of facial expression and 1 or 2 other muscles before entering the parotid gland. Now we must look at the parasympathetic function associated with 7. And we ask ourselves, what is the name of the parasympathetic nucleus associated with the facial nerve? It is the superior salivary nucleus, and we're showing it here as a red dot alongside the 7th nucleus. Do the parasympathetic fibres travel in 7 or in another nerve associated with 7? And although we do regard the chorda tympani as a branch of 7, it actually travels in the nervus intermedius with the taste and general sensation. So now we must ask, what happens to the preganglionic parasympathetic fibres when they reach the floor of the middle ear? We see that they leave the facial nerve and pass back into the middle ear as the chorda tympani. Why do we call it the chorda tympani? This is because it crosses over the pars flaccida of the tympanic membrane before leaving the middle ear. How does the chorda tympani actually leave the skull? Well, it passes through the anterior wall of the middle ear and then through the petrotympanic fissure. We must ask, into which ganglion do these preganglionic parasympathetic fibres enter? And the answer is the submandibular ganglion. This is actually hanging off the lingual nerve. We can look and see which nerve actually carries the chorda tympani to its ganglion, and we see that it is the lingual nerve, a branch of the mandibular division of the trigeminal nerve. What do the preganglionic parasympathetic fibres do when they reach the submandibular ganglion? And as always, they synapse to become postganglionic parasympathetic fibres. Now, what do these branches of the postganglionic parasympathetic fibres do when they emerge from the submandibular ganglion? They go to supply the submandibular gland and the sublingual and anterior lingual glands. We know that these postganglionic parasympathetic fibres can't run by themselves, and they are always carried by specific nerves from the ganglion to their end organ. These fibres are always a branch of the trigeminal nerve. Which branches of the trigeminal nerve are they on this occasion? And we see that we have the lingual nerve already alongside, and it's easy for these branches of the lingual nerve to carry these parasympathetic fibres to their end organ. Then we must ask, what else passes through the submandibular ganglion and is distributed with its 2 branches? And as always, in the head and neck parasympathetic ganglion, there are sympathetics also passing through for vasoconstriction only. In this case, these sympathetic fibres come from the facial artery. Then we must ask ourselves how the taste fibres from the anterior 2/3 of the tongue travel centrally, and where are their cell bodies? Well, the taste travels in the chorda tympani, and its cell bodies are in fact in the geniculate ganglion in the middle ear. And so finally we see the final pathway with all these connections shown. For clarity, we've left out taste on this particular drawing, but we can see that each of the branches that pass out from the submandibular ganglion contain both a sensory fibre, always a branch of 5, a postganglionic parasympathetic fibre, and a small sympathetic branch for vasoconstriction. And that summarizes the pathways of parasympathetics to the submandibular and sublingual glands.